There are two main reasons why there is so much excitement about CAR-T cells. First is that for decades, developing immunotherapy has been considered the next great pillar of cancer therapeutics. Immunotherapy has changed the landscape of cancer therapy, and CAR-T cells are the culmination of about 30 years of that research. The second reason is because of the results. For certain types of blood cancers, the response rates show 90% of patients may go into a deep remission, and potentially 60% of patients can be cured. Given that those patients were effectively out of standard options before this therapy became available, those response rates are staggering. At Roger Williams Medical Center, we are able to treat three main groups of patients at this time with a CAR-T cell therapy called Kymriah. Young adults up to age 26 with B-cell acute lymphocytic leukemia who are refractory or in second or later remission, or adults with diffuse large B-cell lymphoma who have failed 2 lines of upfront therapy, or adults with follicular lymphoma who have failed 2 lines of upfront therapy. The process starts by identifying an appropriate patient for the therapy, who then comes to Roger Williams Cancer Center to undergo a blood collection process called apheresis, where we collect the patient's own T cells. After collection, those cells are shipped to a manufacturing facility where the patient's cells are genetically altered to create the CAR-T cell product, Kymriah. That usually takes 3 to 4 weeks on average. And during that time, we will typically give the patient bridging chemotherapy to keep their disease at bay before the CAR-T cell product is ready to be infused into the patient. We receive the product back from the manufacturing facility cryopreserved or frozen so that we can store it until the patient is ready for infusion. In the 3 to 5 days before the infusion, the patient will come in to have conditioning chemotherapy to prepare the patient's body for the CAR-T cells. On the day of infusion, we bring the frozen Kymriah product to the patient and thaw it at their bedside immediately prior to infusion. Many patients will receive the infusion as an outpatient in the cancer center and will be able to go home after the infusion. Some will be admitted to the blood and marrow transplant and cellular therapy department to have the infusion and monitoring done in the hospital. We follow the patient closely over the next month, evaluating the response and treating them for any side effects they may develop. The process is a collaboration between the referring physician and the blood and marrow transplant and cellular therapy team at Roger Williams. Our coordinators work closely with the referring physician to gather health information that the patient has consented to share and to update each other on the patient's status throughout the treatment process. The only 2 parts of the process where the patient needs to be at Roger Williams or in the immediate vicinity are the 1 to 2 days required to collect the T cells and the 4 to 5 weeks during and after infusion. The remainder of the time, we can work with the patient's local or referring physician to provide treatment and monitoring as well as follow-up after they receive their CAR-T cells. The 2 main risks of CAR-T cells are a condition called cytokine release syndrome, or CRS, and neurotoxicity. The timing of developing these 2 side effects can be different. CRS generally develops within 1 day after infusion to about a week after. Neurotoxicity is usually seen later, about a week to a month after receiving the infusion. Cytokine release syndrome is due to the activation of the patient's T cells after the CAR-T cells are infused. When they are activated, the T cells release chemicals called cytokines, which causes symptoms like fever, difficulty breathing, and low blood pressure. Neurotoxicity is probably also caused by the release of cytokines in the brain and CSF, but it occurs later and affects the function of the brain, causing encephalopathic symptoms like confusion, difficulty speaking or forming words, or can cause seizures. We screen patients to assess the potential risks of developing these side effects and give preventative or treatment medications, and fortunately, in virtually all cases, CRS and neurotoxicity are reversible. These side effects occur early and are reversible, while those seen in chemotherapy and transplant can be prolonged. This is one reason we believe there is an advantage to CAR-T cell therapy. CAR-T cells will also eliminate normal B cells along with tumor B cells, which can result in the patient being left without a healthy number of B cells for a prolonged time. This is called B cell aplasia. That can require immunoglobulin infusions potentially for life after the patient receives this therapy. Like all cancer therapies, CAR-T cells do not work in every patient. There are two main reasons why CAR-T cells do not work. In about 10% of patients, the CAR-T cells do not expand or engraft in the patient after they are infused. In another 30% of patients, they engraft and the patient responds, but then some months later, the patient's disease comes back, usually because it has learned and adapted and no longer expresses the protein that the CAR-T cells are targeting, which is CD19. That's called CD19 escape when that happens. There's a lot of work going into making the CAR-T cells better engraft or to target more than one protein to prevent that CD19 escape from happening. We are the only center in the state of Rhode Island certified to provide this therapy. We offer a convenient alternative to traveling out of state and can provide the same level of state-of-the-art care found in facilities in Boston without the stress and expense of being away from home. This convenience factor is especially appealing to our patients and those who care for and transport them. We also take referrals from areas around Rhode Island who may find it more convenient to travel to Providence for their care. Additionally, we have the only blood and marrow transplant center in Rhode Island with physicians who are used to caring for very sick cellular therapy patients.